Welcome back, friends. In previous video we talk about the drug sensitive tuberculosis. In today's video we are going to discuss about the drug resistant tuberculosis and its management. Most of the presentation has been taken from the guideline from programmatic management of drug resistant tuberculosis in India. For this guideline will be available from the description. You can download Central TB Division website. So basically this is an introductory lecture and we are going to talk about what is the goal of treatment, why there is a grouping of drugs, and before starting treatment for multidrug resistant tuberculosis, what is the pre-treatment evaluation, what is to be done as a part of pre-treatment evaluation, and technical and operational aspect of treatment, follow-up monitoring. And in the subsequent lecture we would be learning the shorter and longer oral MDR-TB regimen as well as the rifampicin susceptible and isoniazid resistant tuberculosis, including polydrug resistant tuberculosis. So in this lecture we will try to cover the basic aspect of the multidrug resistant tuberculosis, prevention and management of adverse drug events, treatment outcome, and implementation, consideration and flow of patient along with drug resistant TB care cascade that we are going to discuss in this particular lecture. So these are the various definitions that has to be used during the treatment of drug resistant tuberculosis, because based upon that the regimen and the duration will depends. So extent or severity of disease in patient older than 18 years, this usually defined by the presence of cavities or bilateral disease on chest radiography or smear positivity, and if the patient is under the age of 18 years, then severe disease is usually defined by the presence of cavities or bilateral disease on chest radiography or extrapulmonary form of disease other than lymphadenopathy like peripheral nodes or isolated mediastinal mass without compression. In children, the occurrence of advanced malnutrition defined by the syndrome or by matrix or advanced immunosuppression or positive tuberculosis bacteriology, smear, NET, culture may also be considered when determining disease severity. Serious adverse event. Serious adverse events are those adverse events classified as grade 3, grade 4, grade 5 or which led to the drug being stopped permanently. In which grade 4, which is life-threatening or disabling, and grade 5 is death related to adverse event. Serious adverse events are otherwise often defined as adverse event that either lead to death or a life-threatening experience, to initial or prolonged hospitalization, to persistent or significant disability, or to congenital anomaly. The management of serious adverse event may require termination of drug suspected of having caused the event. People who use drugs, PWUD, are those who engage in harmful or hazardous use of psychoactive substances which could have a negative impact on users' health, social life, resources, and legal situation. Underweight. In adults and adolescents, underweight usually refers to a body mass index less than 18.5 kg per square meter, and in children less than 10 years to a weight for age less than -2 z-score. So these are the few definitions. So what is the goal of TB treatment? Like we discussed in our previous lecture, that what is the goal of tuberculosis treatment. Similarly, the first and most important goal is to render patient non-infectious so that we can break the chain of transmission. And remember that this time these bacilli are resistant to particular drug, so that is why it is become more important. Then second is decrease TB deaths and related comorbidity by ensuring relapse-free cure. Third is minimize and prevent development and amplification of drug resistance. Because drug resistance is already there, we don't want that it exaggerate or it become worse. So that is our third objective. Grouping of anti-tuberculosis drugs and other consideration. So we have three groups: Group A, Group B and Group C. Group A include all three medicines: levofloxacin or moxifloxacin, that is the fluoroquinolone group of drug. Then newer drug like bedaquiline, linezolid. And in Group B, add one or both medicine that is used from the Group B. And from the Group A, most of the drugs will be used, but from the Group B, one or both the medicine will be used. Group C, add to complete the regimen and when medicines from Group A and B cannot be used. So Group C is used when the regimen need to be completed or some drugs are missing, and when medicines from Group A and B cannot be used. And Group C includes ethambutol, delamanid, pyrazinamide, imipenem, celestine or meropenem, amikacin or streptomycin, ethionamide or prothionamide or para-amino-salicylic acid. The drugs not included in Group A to C are kanamycin and capreomycin, no longer recommended for use in MDR-TB regimen. Gatifloxacin is also not used because of the similar reasons. Then thiacetazone not available in quality assured formulation. Clavulanic acid used as a companion agent to carbapenem. Clavulanic acid basically prolong the half-life of the other medicine like penicillin group of drugs. Bedaquiline, this is direquilinone that specifically targets mycobacterial ATP synthase, an enzyme which supplies energy to Mycobacterium tuberculosis, and that is how it can kill the organism. It is having strong bactericidal activity as well as the sterilizing activities. High volume distribution, and it is having extensive tissue distribution, highly bound to plasma protein and is hepatically metabolized. Drug has extended half-life, present in the plasma up to 5.5 months post stopping bedaquiline. Significantly improved time to culture conversion in MDR-TB patient. That is why it is one of the most important drug when patient is on the MDR-TB regimen. Another drug is the delamanid. Delamanid is a bactericidal drug with 36 hours of half-life. It is having two different mechanism of actions. First one is it can block the synthesis of mycolic acids and it poisons the bacilli with nitric oxide. As per the WHO recommendation, the risk benefits consideration for the use of bedaquiline in patient aged 16 to 17 years and delamanid in patient aged 3 to 5 years are similar to those considered for adults. This slide depicts the patient flow in drug resistant TB treatment care cascade. So this is the treatment cascade, how patient will move. So it depends upon the whether the patient is having the H mono drug resistance or having a poly drug resistance, and whether the patient is having adverse drug reaction and additional resistance is there or not. So if it is a simple case having a H mono and poly drug resistance, then it can be treated as per the guideline to the health facility or peripheral health institution. But if the patient is having adverse drug reaction and additional resistance, then patient will move to the nodal or district drug resistance TB center. And if the patient is having MDR-TB or XDR-TB, then also patient will be treated at the DDR-TB center. And all the patient will be evaluated for the pre-treatment evaluation, before treatment initiation, counseling will be done, monitoring of the ADR, adverse drug reaction, and follow-up will be done. Then NICSI entry, contact tracing, these are the activity which has to be followed. So patient should be traced immediately with the help of community health officer whenever the suspected case of drug resistant tuberculosis is there, because the treatment should be started as soon as possible. If the patient is having a monodrug resistance or polydrug resistance, then treatment can be initiated at health facility that I already described in the previous slide. MDR-TB, it has to be done at the nodal center or district center. Counseling, contact tracing, and contacts of MDR or RR-TB patient with fluoroquinolone susceptible should be put on TB preventive therapy after ruling out that whether they are having active TB or not. And health facilities are responsible for update the information of drug resistant TB patient in NICSI. Care cascade needs to be monitored by TB unit and senior drug resistant TB HIV supervisor. Health education and counseling. Health education and counseling to drug resistant TB patient and their family members about the disease, mechanism of transmission, necessity of taking drugs, and regular and adequate treatment, nutrition, etc. should be discussed. Counseling should start at the initial point of contact as soon as the diagnosis is established and continue during all the visit of the patient at health facility or health worker to patient's home or NICSI Sampark. Although there is a facility of counselor at the most of the NDR-TBC centers, but it is recommended that all the counselor and healthcare workers in the health system need to know the key point of counseling to drug resistant tuberculosis patients. So as and when required, they can deliver the counseling services. So all the key points should be known by them. Confidentiality and informed decision making process is of paramount importance. Pre-treatment counseling. Duly informed decision regarding use of all anti-TB drugs and regimen. Written consent need not to be taken as per the guideline by National Tuberculosis Elimination Program. You need not to take written consent. Training of counselor. There should be counselor register in which they will record the information of the patient for whom the counseling has been done. Pre-treatment counseling include information, these are the components of the pre-treatment counseling: information on lab results, importance of early initiation and adherence to treatment, nature and duration of treatment, possible change in the treatment, care and support services under NTEP, reassurance to the family against stigma, infection control precaution, family planning, and contact investigation of family and TB preventive treatment. These are the things included in the pre-treatment counseling. Counseling during treatment. The duration of any drug-resistant tuberculosis regimen is long enough for the patient which needs multiple sessions of counseling, preferably more frequently in the initial phase of treatment. Explore and address past and present difficulties by the patient on treatment. It might be possible that patient might have taken the treatment drugs, anti-tuberculosis drugs in the past, so that history needs to be evaluated. Maintain confidentiality throughout the treatment. Help to generate supportive environment in the family. Try to counsel family members, relatives, so that they will provide the support to the patient and not the stigma. Help the patient to understand importance of regular treatment as well as consequences of deviation from the treatment, like the amplification of the drug resistance, then the duration of the treatment will be changed, then the side effect of the drug. So it is very important that patients stick to the regimen and the schedule. Counselor register will include the information collected during the counseling sessions. Drug resistant tuberculosis counseling tool. So it has been divided into various points like greet and introduce, education, cough hygiene. So first is to greet and introduce is to build the rapport with the patient and establishing a effective relationship, because the duration of treatment is large enough. So effective relationship will not only help in building the relationship, but it will also help patient. It provide patient support and it help us to complete the treatment. Greet the patient and introduce yourself. Establish boundaries by describing your role clearly, that what you are supposed to do, what you are going to, how you are going to help the patient. Collect basic demographic details. Assure that the information shared or discussed will be kept confidential. Free diagnosis and free treatment under the program. Education include assess and provide correct and updated information, which includes provide basic information on TB and discuss about symptoms of TB. Differentiate between drug sensitive tuberculosis and drug resistant TB. Explain about drug resistant TB diagnosis. Explain about drug resistant TB treatment regimen, duration, side effects, and what he or she has to do for the good adherence and the importance of adherence. Assess and arrange support system available for adherence. Stigma and discrimination, if it is there, then it needs to be taken care of. Patients and its relatives, family member needs to be sensitized regarding stigma and any kind of discrimination in the family. Cough hygiene include cough hygiene and airborne infection control at home, which include discuss about contagious nature of TB, correct cough hygiene and safe disposal of sputum, use of mask, handkerchief, wet mopping. These are the things which needs to be advised to the patient, so that the further transmission of the drug resistant bacilli to other healthy individual can be prevented. Other aspects are the nutrition and diet, Nikshay Poshan Yojana, and other aspects. Nutrition and diet include the nutritious and high protein diet, which is very important, and for that we have to assess the food habits of the patient, advice based on socio-cultural and economic background. Consider underlying comorbidities while advise on diet like diabetes, hypertension, because patient might be on the diabetic and the hypertensive diet, salt restricted diet, etc. Nikshay Poshan Yojana include the welfare scheme that is launched by the government, in which the 500 rupees would be transferred directly into the bank account of the patient during the treatment. This is basically for the nutritional aspect of the patient. Other aspects include re-addiction counseling. If the patient is having alcohol addiction or tobacco chewing or other kind of addiction, then the patient has to be sensitized, advised regarding the quitting those addiction, which will help in the metabolism of the most of the anti-tuberculosis drug, as well as the patient will develop the good immunity and good nutritional status, good physical status, which will help him to adhere to the drug regimen and will help to complete the treatment. Sexual and reproductive health, addressing stigma, discrimination, addressing mental health, family caregiver counseling. These are the other aspects. Key messages for TB counseling. TB is airborne infection caused by germ Mycobacterium tuberculosis. A person contracts TB infection from an open case of TB, usually a sputum smear positive pulmonary TB case. However, infection with TB does not necessarily mean that infected person would develop TB disease. An infected person develops disease when her immunity declines. Prolonged cough for 2 weeks or more, fever, loss of weight or night sweat can be TB disease, and therefore it is essential to consult a doctor and get examined to rule out TB. Sputum microscopy, molecular testing like nucleic acid amplification test, and treatment for drug sensitive or drug resistance are available free of cost to our peripheral health institute under the National Tuberculosis Elimination Program. Diagnosis and treatment services under NTEP are also available to patients seeking care in private sector. So even if patient is taking treatment in private sectors, it will be supported by the National TB Elimination Program. Cure from TB can only be ensured by taking complete and regular treatment. Anti-TB drugs are provided in patient-wide drug boxes, which ensure that the full course of treatment is available. Treatment is provided at a place near the patient's home, which is convenient and acceptable to patient and accountable to the system. Irregular medication or inappropriate regimen are leading cause of drug-resistant tuberculosis. New drugs like bedaquiline, delamanid available under the program are safe and effective. It is important to maintain cough hygiene and take nutritional food as per the custom of the patient. Patient will be linked with the Niksai Poshan Yojana, under which TB patient will entitled to direct transfer of benefit of Rs 500 per month during the entire treatment duration. Contacts of TB patients should also be assessed for signs and symptoms of tuberculosis, and after ruling out TB in contacts, TB preventive therapy should be offered. In events of adverse drug reaction, patient is advised to seek medical consultation. Patient should follow family planning practice during the entire treatment duration. Pregnant woman with drug-resistant TB and the family should be given thorough understanding regarding the need for MTP if the gestation is less than 24 weeks. When risk of delaying treatment, what will happen if the treatment is delayed, like amplification of the drug resistance, possible complications, potential effect of newer drugs on fetus and mother if MTP not opted, and the need for more intense maternal fetal neonatal follow-up. The regimen should be individualized in expert consultation. If pregnant woman with tuberculosis is not willing for MTP or gestation is beyond 24 weeks. Treatment algorithm. So this algorithm will be discussed in more detail in the next lecture. So let us have a cursory look at this algorithm. Rifampicin resistance detected as second specimen tested at culture and drug sensitivity lab. So 4 is the resistant pattern. Then first line probe assay, second line probe assay, then liquid culture drug sensitivity testing, then pyrazinamide, bedaquiline, clofazimine, moxifloxacin, linezolid and delamanid. If the facility is available, then this sensitivity testing should also be done. After completing pre-treatment evaluation, check on Niksai or with culture and drug sensitivity testing lab if line probe assay results are available. If results are available, yes or no. If the results are available and no additional resistance is detected or H resistance is detected with CAT-G or INHA mutation and fluoroquinolone resistance not detected, then shorter oral bedaquiline containing MDR-TB regimen has to be started. And if the and this is also yes. So if the results are available, yes, and the H resistance detected with both CAT-G and INHA mutation or fluoroquinolone resistance detected, then longer oral multidrug resistance or MDR-TB regimen has to be started. And if results are not available and other exclusion criteria for shorter regimen are present, where we can exclude that there is no need to give a shorter regimen, in that case we can start, if it is present, then we can start longer oral regimen. But if the other exclusion criteria not present and result is not available, then we can start with the shorter oral bedaquiline containing regimen. Additional resistance or intolerance or non-availability of any drug in use or emergence of exclusion criteria or return after loss to follow-up or failure, then start of longer oral multidrug or MDR-TB regimen, modified if needed as per the replacement table. So this is all about the treatment algorithm introductory lecture on MDR-TB, how to initiate treatment. In the next lecture we will be discussing the shorter oral bedaquiline containing regimen.